Hi, everyone. Welcome to today's panel, City Multilateralism, the Role of Urban Leadership in Ending the COVID-19 Pandemic. We're fortunate today to be joined by two wonderful panelists, Dr. Shannon Hader, Deputy Executive Director for Programs at UNAIDS, and Dr. José Zuniga, President and CEO of IAPAC and the head of the Fast Track Cities Institute. Before I give some introductions, I wanted to note that we are able to take questions from you in the audience today. So you can enter those in the chat feature. And if we have time at the end, I will try to get to as many as we're able to. Also, we have a lot more panels coming up in this series, which you can see on our website, iapac.org. There's also information about our upcoming Fast Track Cities conference, which I'll share a little bit more about at the end. So to introduce today's panelists, we have Dr. Shannon Hader, who joined UNAIDS in March of last year as the Deputy Executive Director of Program and Assistant Secretary General of the UN. She leads UNAIDS efforts in promoting an expanded and integrated UN system response to HIV at the country, regional, and global levels. A public health physician, her career has reached across research, program, policy, and politics. Dr. Hader holds a degree in biological sciences from Stanford and MD and MPH degrees from Columbia. She is a board certified in internal medicine, pediatrics, and infectious diseases, and has served in national roles at the CDC as well as at the local level in the DC Department of Public Health, which makes her a perfect panelist for today's discussion when we look at these connections between the local, national, and international levels. We're also joined today by Dr. José Zuniga, who is appointed the president of IAPAC in 1999 after having served as vice president for programs. Prior to joining IAPAC, Dr. Zuniga was the director of strategic communications at AIDS Action Council in DC, following his military service in the U.S. Army. Dr. Zuniga earned his MPH in health policy, as well as a doctor of philosophy and human development and social policy, and is one of the co-signers of the Paris Declaration on Fast Track Cities, which we'll be hearing a lot about today. Dr. Zuniga routinely advises UN health agencies, including the WHO and its regional offices. So without further ado, I'd like to turn it over to Dr. Zuniga to begin today's conversation with a brief presentation on the concept of city multilateralism so that we all are on the same page about what we're here to discuss, and to discuss how it's played a role in the Fast Track Cities initiative. Dr. Zuniga?
Thank you very much, Corey, and it is a true honor to share this time with Dr. Hader, who's been an urban, national, and regional leader in the response to HIV. I could think of no one better to be on the panel with, so thank you very much for joining us. I know you're extremely busy. We're also very thrilled to obviously be co-hosting this series of conferences on COVID-19 in the Americas, a region of the world that's been considerably affected by COVID-19, and where we obviously are seeing large numbers of people getting infected, mitigation efforts that aren't quite working in many countries in the region, and a very slow pace of vaccine uptake. In fact, in many countries of the region, vaccines aren't even available. So, from my perspective, this conversation around city multilateralism is a critical one because in many respects, cities and municipalities around the world have had to take the lead in many instances, since the impact of COVID-19 is being shaped by the reality that we are deeply interconnected as people and as jurisdictions, but also the reality that we were woefully unprepared, and that we've had to learn seemingly by trial and error how to manage a new pandemic while planning for a post-pandemic world. And so I'd like to focus my discussion around city multilateralism in action and ask for the slides to be put up. I'll go through them very quickly because I really do want to hear from Dr. Hader and get into our Q&A. Next slide, please. The one after that. Next. So what is city multilateralism? So we are defining city multilateralism as the concept of diplomacy and action that's at the local level to coordinate around global targets and goals and to address transnational concerns, as certainly the COVID-19 pandemic is, but so too are a variety of other infectious diseases. such as HIV, tuberculosis, viral hepatitis, etc. There are multiple urban initiatives that are striving to establish some progress around the global agendas, including a variety of the Sustainable Development Goals, as well as the New Urban Agenda that was approved by the countries of the world at UN Habitat 3 in Quito, Ecuador, a few years ago. City multilateralism also includes achieving a coordination between governments at national level and global movements, including around pandemic preparedness. Again, I noted how unprepared we seem to be to address the pandemic of COVID-19. I'll be speaking to that later in the presentation. I want to stress, though, that we do not view city multilateralism as a replacement for the national health diplomacy model, which has nation states at the center, notably, for example, the member states of the World Health Organization. But in many instances, cities and municipalities have had to engage in harm mitigations when nations have failed to lead, not just around COVID-19, although I'll get into two examples of failure at a higher level of jurisdictional leadership, but also around HIV, TB, and viral hepatitis. Next slide, please. So a bit about the Fast Track Cities initiative for those of you who are unaware. This is an initiative that was launched on World AIDS Day 2014 in the city of Paris with 4 core partners: UNAIDS, IPAC, the City of Paris, and UN Habitat. We started out with 26 original cities signing the Paris Declaration on Fast Track Cities ending the HIV epidemic. We are now at over 300 cities that have joined the initiative since 2014 in every region of the world. And notably, in some countries, we have recruited a critical mass of Fast Track Cities in Brazil, France, Portugal, South Africa, Spain, UK, and the United States, for example. We have recruited these cities in an effort to have an impact on national HIV epidemics. And some of the modeling that's been done by UNAIDS and IPAC around HIV epidemic control has demonstrated that it is conceivable to control HIV epidemics if we can move the needle as far as 90, 90, 90 and other targets at subnational level. Next slide, please. 3 examples of what I'm referring to. So in this slide, we see 90, 90, 90 data for the Bangkok Metropolitan Administration. And I think it's important to note, for example, in relation to the first 90, or the percentage of people who know their status, that from 2016 to 2018, we saw an increase percentage point from 79% to 91% as a result of concerted efforts at the urban level to implement evidence-based interventions, data-driven, that could address the gaps in the numbers of people who were getting tested and ultimately linked to care, which represents the second massive improvement around the second 90 from 2016 to 2018, from 57% of people who knew their status on ART to 70%. Clearly still room for improvement, but a demonstration, proof of concept, that it is possible to achieve these types of improvements at subnational level. Next slide, please. Looking at the city of Kyiv, here too, from 2015 to 2019, we've seen just remarkable progress made as a result of city leadership, inclusive of a mayor who had no political reason to cash in political chits to bolster his city's HIV response, a highly ideological country and city, and not one that had partnered very well with community-based organizations, particularly those representing key populations. But that changed as Kyiv joined the Fast Track Cities initiative. And if we just focus on the third 90, that improvement has been quite significant. The second 90 from 44% in 2015 to 83% in 2019 is quite remarkable. Again, not something done in isolation, and in many respects, a reflection of the ability of the city administration to work with the national government around an HIV strategy that leveraged a significant investment on the part of PEPFAR, for example, towards ART provision. Next slide, please. Finally, the third fast track city I'd like to focus on is Nairobi County. And here too, from 2016 to 2018, we saw significant progress. Just looking at the third 90, from 2016 to 2018, we went from 55% of people on ART virally suppressed to 92% virally suppressed. This reflected, again, an alignment between the national strategy and a local fast-track city strategy that was developed in conjunction with the national strategy, a significant investment on the part of PEPFAR, and honestly, a tremendous amount of work done jointly by UNAIDS and IAPAC through a 15-city project that we've been engaged in for quite a number of years. Next slide, please. So, getting back to the topic of city multilateralism, why? Why are we focused on it? Well, UN Habitat tells us that 2 in 3 people on this planet will be living in urban centers by 2050. And we know that about 90% of that growth is occurring in sub-Saharan Africa and East and South Asia, where we see a large proportion of megacities growing exponentially. Additionally, we know from UN Habitat through its multiple indices that 75% of cities have grown less equal over the past 20 years. And that inequality and inequity in access to health and other services is certainly highlighted throughout the COVID-19 pandemic, as we see large numbers of people not being able to access a variety of services that are critical to their health and well-being. There's also risk and opportunity in city multilateralism. As far as risk, urban growth is a risk because infectious diseases impact cities with large populations, and that has a significant ripple effect as far as numbers of people and burden of disease. But on the opportunity side, and there are other risks, but on the opportunity side, we are seeing city and municipal leaders stepping up to the global table, and in some instances, rallying their citizens around mitigation efforts, for example, that evidence-based mitigation efforts that are sometimes eschewed by national leaders. Finally, I think another important opportunity is in relation to the fact that healthy and resilient societies require that concept of the right to the city enshrined in the new urban agenda, which asserts that a city or municipality is a place that strives to guarantee a safe, inclusive, and sustainable life for all of its citizens. Next slide, which in many respects is the essence of SDG 11. I'd like to cite 2 examples of city multilateralism in action in relation to COVID-19 by highlighting the cities of Atlanta and Sao Paulo. In the city of Atlanta, Mayor Lance Bottoms has been a remarkable public health leader in her role in leading one of the most populous cities in the United States. She coordinated with state governments, but also with the CDC and with philanthropists. And although she herself does not control the health budget for the city of Atlanta, that is at the county level, a higher level than the city, she took a leadership role in ensuring that she provided that coordinating mechanism, which is critical. And I'm happy to say that that coordination is extended to her colleagues in Fulton County. And we've seen just a remarkable response, not just to COVID-19, as overwhelming as it is to the city of Atlanta and Fulton County, but also in relation to maintaining a continuity of HIV services in a city with a heavy HIV burden. They followed recommendations from the CDC and WHO regarding closures and masks, and persisted despite remarkably confusing and politicized federal and state responses, both the US and the state of Georgia responses. She even went as far as facing down the governor of Georgia from a different political party, who filed a lawsuit to end her ability to close her city and mandate masks as mitigating factors for COVID-19 spread in that city. That is city multilateralism in action. So too we saw in the city of Sao Paulo in Brazil, which saw some of the earliest cases of COVID-19 in that country, especially in the favelas. Here, the municipal leaders worked with the state leaders to prepare hospitals very early on. You would have expected this to happen at the national level. It occurred at the municipal and state level. They started canceling elective procedures, expanding ICUs, and acquiring PPE supplies that the national government should likely have, well, not likely, should have done. Finally, it goes without saying that regrettably, these leaders were mocked by the president of Brazil, who encouraged people to defy lockdown measures. That is what leaders do. They go against non-evidence-based, politically ideological stances that put citizens at risk. Next slide, please. So again, we're not calling in advocating city multilateralism for a dismantling of the existing health diplomacy infrastructure. What we are calling for, though, is a recognition of and the actioning of city multilateralism. And here I'm very happy to report that work is ongoing with Unite, a group of international or global parliamentarians who understand that the response to infectious diseases cannot be isolated to the national or even the global levels, but that urban leaders have a right to speak to and commit to any of the global targets and goals that we set for ourselves. As important, SDG 11, which I've spoken to already, is something that under a decentralized health diplomacy infrastructure can be supported, and specifically the creation of sustainable cities and communities becoming a priority so the cities are not acting in isolation. Next slide, please. Again, here in relation to the national partnerships, what we call on from national governments is to avoid becoming obstacles and to empower cities to take the critical measures they need to, especially regarding issues such as inequities, implementation of innovation, so that cities and municipalities can be laboratories of innovation, and in many respects, they can do so in an accelerated fashion that can then be a proof of concept for national scale-up of these interventions, including, for example, around continuity of HIV care, multi-month dispensing of ART, a differentiated service delivery, innovative ways of facilitating telehealth and telemedicine. And then finally, there's a role certainly in addressing the social determinants of health, because HIV, COVID-19, none of these diseases live in isolation of the significant barriers that people face to accessing and utilizing health and other critical services. And here we're speaking to issues such as housing, socioeconomic opportunity, and addressing the stigma and discrimination, including intersectional in nature, that violate people's human rights. There is an opportunity through advancing these national partnerships to look towards long-term cooperation and make space to have that national urban partnership around infectious diseases. And here too, the work of Unite is going to be critical. Finally, there is a role within these partnerships to coordinate public health efforts around the health-related SDGs, but also going forward as we enter the post-COVID-19 era, pandemic preparedness. Next slide, please. So I'll close just by reviewing that cities must be at the forefront of public health and human rights. Our 300 plus fast-track cities around the world certainly are. And that, I think, presents an opportunity for many more cities and municipalities around the world to engage in that level of city multilateralism. We can't relegate our urban leaders to the sidelines and expect them to play a critical role in health crises, as we've seen in too many cities and municipalities around the world, where in some instances, city and municipal leaders have been demonized. We need city multilateralism to serve as engines for change and innovation. And finally, I would call on national leaders to see city multilateralism as an opportunity, not as competition. We're all in this together. Next slide. Thank you very much. I appreciate your time.
Great. Well, thank you so much, Dr. Zuniga. I look forward to following up on some of that during the Q&A. But for the moment, I'd like to turn things over to Dr. Hader just to talk a little bit about your experience and why the role of cities in your opinion is important for dealing with the COVID-19 pandemic and other pressing public health challenges that we face.
Yeah, thank you. And thank you to the organizers for the opportunity to join this discussion. Always like to join a discussion on such important things. And I think, from UNAIDS, we look at the colliding pandemics of COVID-19 and HIV. And certainly, what are we seeing? Across the world, cities, urban settings are heavily affected by the COVID-19 pandemic. This is not surprising, right? They are a center for concentrated and large populations. Cities are hubs of economic and social interconnectivity of people coming in and out and sort of traveling a lot. And of course, we have individual and community level vulnerabilities that we see in urban areas. In fact, that brings me to another reason why I think this concept of multilateralism for cities is so important. For many cities, COVID-19 is a health crisis which is aggravating so many inequalities that matter to people's day-to-day lives. And as the United Nations, we care about reducing inequalities. These are showing up as health disparities, who lives and who dies. These are showing up in safety from violence and human rights. And the impacts of widening inequalities are showing up on finances, on employment, on public services. When it comes to health disparities and life and death, and I think Jose mentioned a few of these, who's been most likely to be exposed to COVID, to get infected, to die from infections? Disproportionately, we see axes of inequalities, of poverty levels, of race, and of gender interacting with the COVID challenge, creating conditions of higher exposure to COVID. Jobs that don't have remote working as a possibility and require a lot of exposure to the public. We see conditions in urban areas that limit prevention options, crowded housing, poor sanitation. We see the effect that existing health conditions and health disparities, rates of diabetes, hypertension, TB or lung disease, that reflect lots of healthcare access and prevention failures over time, playing out in COVID-19. And I think Greg Millett has a lot of really good data, for example, from the US that shows Black and Hispanic and Native Americans are disproportionately dying from COVID-19. In New York, we've seen cases and hospitalizations and deaths really relate more to poverty levels than a lot of other things. And globally in the data, we've seen racial, ethnic, immigration status disparities within countries, things that are really prominent in urban areas many times, related to bad outcomes for COVID-19. When it comes to safety and human rights, we are seeing all sorts of violence against women and girls, particularly intimate partner violence, intensifying since the outbreak of COVID-19 across the board. We've seen other abuses of human rights. In Puerto Rico, during lockdown, there have been reports of increased violence and murders among transgender people. In Colombia, we've seen reports of transgender people being unable to access public services because they were out on the day that corresponds to their gender identity rather than the gender marker on their identity documents. Excuse me. In Jamaica, UNAIDS has heard testimonials from gay men and other men who have sex with men living on the streets who have been harassed by security forces to comply with the curfew. And other kind of inequalities that really play out in COVID-19 in urban areas. Finances, employment, public services. We know that worldwide urban economies are important. They're about 80% of the global GDP, which of course matters to jobs and it matters to people. The effect of COVID-19 on job losses has been particularly severe in the informal sector. In Africa and Latin America, informal workers lost as much as 80% of their earnings, with devastating effects, especially on women. And there are indications that COVID-19 will be reversing poverty trends, that up to 1 billion people could be pushed back into poverty. UN and World Bank estimate that local governments may lose on average 15 to 25% of their revenues for 2021. And this loss could severely affect urban infrastructure investment, lead to cuts in public services, and undermine that broader SDG goal of sustainable urban development. And of course, as Jose's mentioned, many of the innovations and solutions for COVID-19 are coming from cities like they've come for HIV. And I know you'll be exposed to more examples in other presentations. And so this goes back to a little bit of what Jose started presenting. You know, if cities are so critical in COVID-19 and they're a hot spot for both the impact and the responses, why is multilateralism in response to COVID-19 and other pandemics not something that's automatic? What gets in the way here? And I think the reality is, for the UN, cities are not the usual partnership. I've been at the UN almost 2 years now, and I realized in my first meeting that crossed agencies, that had my peers from about 70 different agencies, that really it was UNAIDS and UN Habitat, both of whom are partners in the Fast Track Cities initiative, who dealt more often and more commonly with cities and urban leadership itself. And as Jose's mentioned, you know, diplomatic relations and deals and UN funding is usually through national authorities, the member states. And beyond just what is usual or not, we all know there are complexities of jurisdiction that vary tremendously by country. And therefore, in any specific country, it takes a little bit of mapping and negotiation to identify and form those relationships with urban leaders. And that one size fits all of what you're negotiating, you know, just doesn't apply to cities. You know, how do national resources and authorities relate to the local resources and authorities? What is local? Is it a city? Is it a county? How do leaders, politicians, budgets, authorities, people served line up? And so what it takes at city level is definitely coordinated local planning and responses, strong local leadership. Those provide some of the best settings for multilateral engagement, like the UN connection, to be able to work more effectively and more quickly. And when I say leadership, and leadership is really key, yes, political leadership, the mayors, the county authorities really matter. But frankly, the advocacy and leadership must come from many different areas in that urban area. It can include community and civil society, but also service providers. Providers can be extremely strong advocates for ensuring their own and their urban colleagues' seats at a lot of these planning tables. So what does that mean as we look forward? Well, you know, we know that COVID-19 pandemic is far from over. So we at UNAIDS continue to try to work out new partnerships and new ideas on how to respond distinctly to COVID-19 and HIV in urban areas. One example is bringing together UNAIDS and Africa CDC with local community-led organizations who must connect to providers and local governments. We are targeting the place in this partnership of unfinished business for HIV and the joint high vulnerability for COVID-19. What do I mean by that? Informal settlements, slums, high density areas. These are places that, despite high and disproportionate health needs, rarely have the infrastructure and services to scale, from clean water to local service access to HIV, TB interventions, etc. So we hope that we will be able to respond to the urgent needs of COVID-19 to connect health and communities for testing, prevention education, and prevention protection tools, and now soon we hope to vaccines. Some examples of how this will work out, and these are just our early models, and I think they're important for thinking about innovative partnerships for other regions of the world as well. In this case, with Africa CDC in Malawi, we'll cover 3 urban centers with 1,500 community leaders to be trained and involved in the response, and working in the 3 cities where 70% of the COVID-19 cases nationwide have been recorded. In Cote d'Ivoire, we have activities that will cover Abidjan, where 95% of the COVID-19 cases have been reported, and so on and so forth. So I'm just hoping that we can continue to build on the capacities and competencies of some of our HIV expert communities and work together with new partners to really focus on these high-risk urban areas for new solutions. And then I think finally, we have to take the lessons from the COVID-19 response and situation, and that with, from nearly 40 years of the AIDS response, to continue to support cities to transform and partnerships in cities to be better prepared for future pandemics and more resilient. I truly believe our HIV experts must be at the table for pandemic and universal healthcare infrastructure discussions in order to make sure in those discussions of looking forward that community-led infrastructure is seen as part and parcel of the response system and not something that is added on or that's unfunded or that's optional. I think we need our experts at the table because really the only effective responses for public health are rights-based responses, and we've seen the liability of not doing that yet again under COVID-19. And also because in the response to COVID-19, in the preparedness for the future and for more resiliency, I think agility is really key. Ensuring the systems that are strengthened in a way to be agile and responsive to the people and issues at hand, and not just one size fits all. And that's particularly relevant for cities because, we need to make sure that cities are not relegated to a national one size fits all response. And I think this is where creating some direct multilateral partnerships for health, like we do for HIV and for habitat, is really, really important. And I think if we're left with a few things on that, we have to be really clear from the lessons we're learning under COVID-19 that even as economies are struggling, even as recovery is really not yet in sight, we at global level, folks at national level, at city level, can't afford not to invest more in health going forward. Recovery can't be a time of pure austerity for health in cities because we're living right now what happens when we fail to invest in health before there's an event like COVID, and how expensive that becomes for lives and frankly for the economy and sustainability. So in recovery, we've got to really build this new normal where the impacts of COVID, of a COVID repeat, become unimaginable. So those are some of the things we're working with at UNAIDS. Jose, back over to you, Corey.
Great. Well, thank you so much. I really appreciate that. And going to start now with a couple of questions for you both. Again, if anyone in the audience does want to ask anything, feel free to put those through in the comments and we'll see if we are able to get to them. Dr. Hader, just to follow up with you first, given that you do have experience ranging from the local level to now the global level, are there any kind of specific lessons or experiences that you take from your time working at the city level that kind of help inform the work that you're doing now to support other cities around the world?
Yeah, I'm very passionate about working at city level, and I think I'm very, realistic about the challenges too. So, I worked at DC government level, and a few things I think in those lessons really hold. Number one is that leadership absolutely matters. I was lucky enough to work for a mayor who was like a young, new, innovative mayor, Mayor Adrian Fenty, who essentially told me when I walked into what had been a really poorly mitigated, ineffective, response to HIV at the city level, he's like, as long as you have evidence for what you want to do, it's evidence-based and it's going to work, I'll support you, even if it's hard, even if it's controversial. And he did. And so I think with that support, with community members and civil society who had, the reason the mayor was that supportive is they had put that on the agenda with the mayor saying, hey, change around the response to HIV. The second thing I learned is that at an urban area, you can transform your outcomes and impacts very rapidly, very, very rapidly. In DC, where we had about a 5% HIV prevalence among adults when I showed up, we were able to, in just 3 years, and this was 2010, so it wasn't a long time ago, in just 3 years, we were able to reduce death from AIDS by 30%, increase treatment coverage 50%, institute the first ever locally funded needle exchange project and comprehensive harm reduction that got about 300,000 needles off the street in the first 12 months, And then we subsequently saw the HIV prevention impact of new diagnoses of HIV falling among people who use drugs. So that was, really dramatic outcomes and transformations in just a few years. And I think that is something critical. It's a lot harder to get a consistent response across the nation, particularly than when different areas of the nation need different things. At an urban area, when you line up the partners, you can really push forward quickly. And I think we've seen with COVID-19, when there's sort of political will, how rapidly a bunch of things can change. And certainly that is even more true with local leadership at an urban level.
Thank you very much. Yeah, I was living in DC during that time myself and working in HIV, and just even seeing people come in and out of the clinic, and the people's attitudes towards the virus really changed during that time from something that was much graver to something that people were feeling more optimistic about. So definitely could see that at the local level. Dr. Zuniga, thinking forward, how is IAPAC going to continue supporting the concept of city multilateralism with respect to the Fact Track Cities Initiative, especially, where we have the ongoing need to address things like HIV. We also know that the pandemic is not going to be over for a long time, especially for lower income countries where there's really been a dearth so far of supply of the vaccine. So these are long-term problems that all need to be addressed. And I'm curious what you think looking forward as far as your role in supporting this work.
Thanks very much. So I think critical for us is our continued partnership with UNAIDS and UN Habitat to highlight the importance of making up for lost ground as a result of COVID-19 in relation to SDG 3 and SDG 11. As I already noted, equally important for us is this partnership with UNITE to convince the unconvinced amongst national parliamentarians that city and municipal leadership is absolutely crucial, and to demonstrate that through the impact that city and municipal leadership has had in relation not just to COVID-19, but going back to HIV, looking at TB, looking at viral hepatitis, looking at other health conditions that have been, in many respects, helped tremendously through the political will and political leadership to address those health conditions at urban level. And as Shannon noted, not just amongst the politicians, but amongst other key stakeholders, because ultimately it's my firm belief that we are all politicians in one sense or another. We have a commitment, or must make a commitment, to affect the change that we need within our respective communities. Otherwise, just placing that faith at the feet of elected officials is certainly not enough. We will leverage the Fast Track Cities 2021 conference in Lisbon, which will likely be a hybrid conference, to highlight the best practices that we have been able to document in relation to COVID-19, continuity of health services, but also start laying out the foundation for the health policy discussions that I think are going to be critical going forward. There are significant budgetary constraints that countries will face over the next couple of years, and I fear a temptation perhaps to reorient health funding towards pandemic preparedness at the expense of other disease responses, including HIV. And let's bear in mind that I think the leveraging of the HIV infrastructure, including the health workforce, has helped to make a situation that's already horrible a little less horrible, because we had that infrastructure to rely upon. And then finally, in relation to vaccines, I do think there is an important role that cities and municipalities can play in relation to vaccine distribution. And where we are seeing that happen, we are seeing uptake, but regrettably, we're not seeing it across all communities, which I fear will also lead to the type of disparities that we've experienced in relation to COVID-19 infections. So if we don't want to see that, we need to commit to this idea of a people's vaccine and ensure that no one is left behind as we push these vaccines forward to try and stem the tide of new COVID-19 infections.
Thank you. Speaking of, some of the innovations and emerging best practices that you mentioned, Dr. Zuniga, I'm wondering for Dr. Hader if you can speak towards anything that you're seeing now, with respect to interruption of services and some of the challenges that have been faced, but also some of the innovations that are coming out of that and some, emerging best practices that we may be able to carry forward in terms of addressing long-term issues like the HIV epidemics that these cities are facing.
Yeah, towards the beginning of the COVID epidemic, we did some modeling and sort of said, how bad could COVID be for treatment interruption? Like, if we just don't do anything, how bad it could be. And some of that modeling showed, for example, a 6-month interruption in treatment for sub-Saharan Africa alone could essentially double deaths from AIDS, taking us back a decade in our mortality rates in just 1 year. So I think nobody wanted to sit around and just let things happen anyhow. But if you needed more fuel to understand, like, why is it so urgent to intervene? This was part of it. And so we've seen a variety of responses. We have seen in many cases treatment coverage for HIV stay stable or recover. And I'll talk a little bit about the partnerships and the innovations and the working together that made that happen. Yet at the same time, we have seen a real non-recovery, a dip in non-recovery in HIV prevention services, especially for key populations. So what's not happening there, and what are the, how do we change that? One thing that's been really interesting to see for HIV treatment services, first, huge attentions across global and national partners on trying to not just ensure supply chains for the actual medications for treatment, but to problem solve around them when there were threats of interruptions. And I think it was really that pulling together in any which way that was quite useful. Probably as importantly, if not more importantly, there have been a lot of innovations over the last few years for HIV services and how they're delivered that have been part of WHO guidelines, and they've been recommended, but in many countries they hadn't been fully implemented. So differentiated service delivery, these more agile, person-centered modalities to deliver services that were a lot less about people going to services and more about services going to people. And, countries that had implemented some of these modalities before COVID, like multi-month dispensing, so that as a client, someone could pick up 3 months or 6 months of a drug at a time, rather than having to go back to the clinic every 2 weeks or every 6 weeks. Countries that had implemented that beforehand really moved a lot more quickly and agilely for COVID-19 with less impact on their health services and systems. Zimbabwe had already implemented 3-month MMD, had seen a 30% reduction in their health service utilization because of that before COVID-19. So they had a lot more agility with their infrastructure when COVID-19 came up to respond. And so what we have seen is we've seen a whole host of countries that had not actually moved on things like MMD before COVID suddenly go to 3-month and 6-month MMD, suddenly make policy changes so that treatment services and treatment initiation could be happening at community level, at community sites, so that self-testing could actually become a modality in countries. So we saw both large, rapid policy changes, but probably more important, fuller implementation of those policies of agility than we had seen before. On the flip side, for HIV prevention services, and we're still learning about that, I think there have been things that have gotten in the way. Certainly effective combination HIV prevention, particularly for key and vulnerable populations. Oftentimes the most effective combination services are delivered by community-led organizations, by the community for the community. And in so many places, community-led organizations and people working there were not considered essential providers under COVID-19. Couldn't get to the office, couldn't get to their people, couldn't have the resources, couldn't get the personal protective equipment needed to deliver to their clients effectively and to their communities effectively. And so I think, we have seen innovations around that. We've seen countries where community-led organizations in collaboration with the health department or health service providers have worked together to reach folks effectively. We've seen the institution of sort of tele-reaching people rather than forcing them to come to a site. All those are good, but I think this real key issue of making sure we are supporting HIV prevention services at scale for the people most affected by HIV, most likely to, be involved in HIV transmission in ways that the services can reach them, in ways they want to access them, from who they want to deliver to receive those services. And I think what we're seeing now with COVID-19 is we're a far cry away from doing that fully and well yet. So it's a reminder to us on the HIV response of what's got to change.
Yeah, very interesting. And I wanted to touch a little bit more on that topic of kind of community engagement and the importance of community organizations and just the interplay between cities and communities, since we've seen during the pandemic how much responsibility has been put on city governments to be communicating with their local populations, especially vulnerable populations who may not be trusting some of the information that they're receiving. So I'd like to ask this question of both of you, and I'll start with Dr. Zuniga, just around, what have we learned about community engagement, and what is the role of the city government in supporting that engagement and communication?
Thanks. Great question. I mean, there's been a tremendous amount of misinformation around COVID-19 from almost the beginning of the pandemic. And that misinformation, sometimes willful misinformation, has resulted, I believe, in lives lost that should not have been. What we've witnessed across the Fast Track Cities network is a real embrace by city governments of the role that community can play, not just at sitting at a table and being part of developing strategies, but actually in relation to implementation. It really has been remarkable, and I think there's a significant role for community to continue to play going forward in helping to generate, create and generate demand for a variety of health services, including in relation to the COVID-19 vaccine. We'll see that equally in the HIV space as new treatment modalities and hopefully prevention modalities come online. It's not a given that simply getting a drug or a diagnostic approved will guarantee that people will take it up. And so that is also a space where community champions can play a significant role to ensure that from bench to clinic and ultimately to community, we close the gaps as far as implementation is concerned that have too often led to increased morbidity and mortality.
Great, thank you. And if I could ask the same question for you, Dr. Hader.
Yeah, I think about the role of particularly community-led organizations of people for the people they're serving, in really three major strategic areas. One is definitely being at the policy and planning and decision-making tables. Another is being at that sort of direct service delivery implementation, stream. And a third is being part of accountability. So, community-led monitoring that checks in real time is what's been promised being delivered. What are the new problems we're finding out so that we can close the gap? And interesting, Jose, I would totally agree with you. I think when it comes to direct service delivery, this is where people have, cities have seen, countries have seen, really at the local level, the major innovations and the pulling together for direct implementation for COVID-19 responses. A little scarily, though, that first part of having a seat at the table for policy and planning and decision making, we have not seen a lot of that under COVID-19, nowhere near the kind of what we expect for the HIV response. And that's just so important, because I think we have to remember those tables are not just about whether to do something, they're about how to do it well so it works for people. So if we're going to be doing public health restrictions on traveling and mobility, then who are the folks who are extremely vulnerable because of that, made more vulnerable because of that? And what do we need to provide for them so that we're not worsening their vulnerability or abuse? And I think missing the community-led voice at those tables has had profound impact for the effectiveness of decisions, the consistency of messaging around those decisions, the believability and relevance of those messages and decisions. So that's a real problem. And I do think things have been moving very fast. But as we go forward, and I think particularly as we go forward, hopefully, of really breaking through these access and unequal access issues around vaccines, that community-led monitoring is what's being promised, being delivered to whom, how well, how effectively needs to come in play as well to just increase the confidence across the board that we're going to be able to get this under control.
Great, thank you. And if I could ask just kind of a final question for you both as we wrap up here, starting with Dr. Zuniga, kind of what are your hopes for 2021? We have a lot left to do to address the COVID-19 pandemic. We also can't stop our work on issues like HIV. So with respect to the role of cities, what are you hoping to see over the next 11 or 12 months?
Thank you. I would like to see a thorough documentation of just the agility that Shannon was speaking to and what cities and municipalities have done to leverage resiliency plans, et cetera, to maintain a continuity of HIV services at the same time that they're addressing the novel coronavirus. I'm also hoping that as we start planning the post-pandemic world, we don't resort to business as usual. That is a huge concern, and that part of that business as usual is always focusing on what's shiny and forgetting what we've invested in over a long period of time. I've noted earlier that I believe that the return on investment of our HIV response over so many years did significantly contribute to our ability to address the COVID-19 pandemic in many cities and municipalities around the world. And without that infrastructure, we might be worse off. And I'm not suggesting in any way that we're not in a terrible space, but it might have been much, much worse. And then finally, I would say, just having commemorated Martin Luther King Day here in the US, that we maintain a focus on inequity. I would like to think that if I had to paraphrase one of Dr. Martin Luther King Jr.'s speeches, he might say that inequity anywhere is a threat to everyone, everywhere. I mean, he did say that we live within inescapable networks of mutuality, and that certainly is true. And again, another reason to argue for and promote and facilitate this multilateralism between cities, municipalities, and countries.
Thank you. And Dr. Hader, on your end, what are you hoping to see this year as we address, COVID-19 and HIV and other public health issues?
What I would really like to see for urban areas especially is in fact, using everything we have to do this next year. Now that we're a little bit more grounded than we were a year ago this time. We know more what we're dealing with. We know what's in the pipeline. We know we're not there yet. So I would like to see, number one, a recognition that urban leadership matters and a reinforcement and a support for that. Number two, within urban areas, I'd like to see an intensification of services and commitment to those underreached and highly affected areas, like slums, like informal settlements, like if you take out a map where you're seeing the disproportionate mortality and bad outcomes. So even not a one-size-fits-all at urban areas. And I think urban areas can be very good at doing this. And third, as part of that, I think we're going to be moving into a bit more of a multi-disease model as we go through this year. So it's not just about a COVID rapid test or not. It's understanding, what are your comorbidities? Do you have diabetes, hypertension, lung disease, TB, HIV? Understanding more what people's needs are, where, and so that those can be addressed and can build trust over time as we're planning for vaccine rollout, as we're trying to reach people. So really bringing in that multi-disease model more effectively in those same concentrated areas. And then I think fourth, the way to do that best is to make sure community-led people and organizations are a key part of that infrastructure in collaboration and in partnership with professional healthcare workers and in partnership with political leaders. So, just small little requests as we go forward to hopefully what will be a year on the way to a much, much, much better 2022.
Yeah, very, very interesting. And I think certainly we've learned that the middle of a public health crisis is not the ideal time to have to be building those partnerships and building that trust at the community level. So hopefully one thing that we can all take from this, those of us who are working in public health, is a renewed energy to work on that moving forward. So thank you both so much for joining us today for this panel, and thank you everyone who has joined us in the audience. Just as a reminder, we have lots more panels coming up. So that's one thing that you can look forward to in 2021. So if you go to iapac.org, you'll see the information for those upcoming panels as part of this conference, as well as the Fast Track Cities 2021 that Dr. Zuniga mentioned, which will be October 20th to 22nd in Lisbon, hopefully, and assuredly some virtual component as well. So thank you both. Really appreciate you being here, and look forward to continuing the conversation in future panels.
Thanks, Corey. Thank you, Shannon.
Bye-bye.